Hi, Mike Schmidt again from Ensemble Ventures. We're here with our second interview on our healthcare IT series. I've got the pleasure of having Mr. Jim Kalani, who is the Chief Technology Officer for the Community Health Partnership right here in Colorado Springs. And Jim and I are going to do some interesting discussions today, talking a little bit about some healthcare records and some of the community information needs for service providers that are tapping into these unique networks. But Jim's got quite a history in doing work in the healthcare space. He's also been his own independent consultant for many years and doing strategic planning for life and management cycles. Looks like a BA from University of Texas in Austin. So we got a Texas guy, Aspen MBA, and you also got biology and chemistry as well.
Yes.
And a JD in law.
One day I'll figure out
what degree don't you have, Jim?
I'm a recovering
I think you're going to win the credential award for our interviewers this time. This is great. And I actually was going through your bio, and I saw a very interesting overview of this thing called Invisible Diabetes Association.
Disabilities.
Invisible Disabilities, sorry.
Sure.
Could you tell us a little bit about that? I was intrigued with this mission of this organization. Just tell us a little bit about it.
Sure. So I'm a board member and the secretary of the organization. It's a non-for-profit, and it really is focused on growing awareness of disabilities that you can't see. Anything from diabetes to cancer to other things where many times people think you must be okay because you look okay.
That's right.
And so it's a big issue, and this organization is associated with a lot of fundraising events that we do to try and help that community out.
Very good. Well, your square job obviously is back at the Health Partnership. So as a Chief Technology Officer, maybe you can give us a quick overview of kind of your mandate or charter there and what you're doing on a day-to-day basis. Because I understand you've just been there a year and 3 months. Right. So you're kind of getting the lay of the land and figuring out what's going on. Tell us a little bit about that.
So the initial charter when I came on board was to deploy a health information exchange system for our community. When I came on board, there were various ways to do that were investigated, and we made a decision at the executive level that it would be best to partner with our state health information exchange, CURIO.
Exactly.
And work with them to build out the technology that would be best. They're the state designated HIE.
Right.
And so we've been in that process. We finished, we did a demonstration project with 3 of our main Medicaid providers. It was very successful.
Very good.
And I don't, as Mark Carlson may have mentioned, CURIO is mainly connected to the acute setting facilities, the hospitals throughout the state. So this was the first time to really have an active go at connecting ambulatory primary care provider practices, specialty practices. I'm happy to say it went well. In January, we started full deployment across the rest of the region.
Oh, very good.
So we are slated, hopefully this year, to onboard up to 30 new practices, which will be new data, new health data from primary care providers that will also be in the CURIO HIE.
Excellent.
And accessible by other physicians that have a relationship with the patient as well as hospital providers.
Now this is, and trying to understand this for our audience, there's basically 7 regions within Colorado. We're in what's called RICO 7, is that the correct one? Could you explain a little bit for our audience what that is? Sure,
so there's 7 regions that Medicaid is separated into as far as the administration on the clinical or physical health side. We are in Region 7, which is a 4-county region. That's El Paso, Elbert, Park, and Teller counties.
Got it.
Okay. There's obviously 6 other regions. Each region is charged with administering Medicaid for their region. They don't pay claims, but they manage the administration of Medicaid funds in those areas. The behavioral health side is a different area, and they're separated in different regions.
Got it. And the total reach now, even though you're going through the primary care providers, are you reaching out into any alternative care providers, or even like the safety net clinics that we mentioned earlier in our interview with Mark for CURIO? Are these organizations now having the ability to attach into this community network, or are they still a ways out?
Yeah, Mike, that's a great question. So with anything, any new project you're trying, a new technology, we try to keep expectations low until we make sure it worked.
So that's good for job security.
It's good for job security, and it's good to impress people when you keep the bar low. We actually were very successful, and so the next gen is not only gaining critical mass, which enhances participation in a health information exchange. The more records that are in there, the more valuable it is for a new participant to incorporate records in.
Interesting.
So this year we're focused on primary care providers and specialty providers that have relationships, so it makes sense for them to move forward. But our next gen really is incorporating the health information exchange along with a technical tool, a care coordination tool that assists in care coordination. And our vision right now that we're moving, that's the next gen, but to answer your question, we are very quickly moving forward to at least viewability by, let's say, some of the organizations that treat the less fortunate population, usually the ones that don't have enough money to really build an infrastructure. So we're looking at ways that CHP can provide that infrastructure, even if it's just iPad viewing or a terminal into view the data that we've collected not only at the Health Information Exchange with Creo, but also other data that would include SED clinics, social services, foster kids. And I told my team, so last year we enjoyed spending our lives in primary care facilities and convening those folks, and I made it very clear that this year we're going to be spending our lives in jail, and we're going to be spending our lives in the Department of Correction and homeless shelters and food banks and things like that.
So you're going into orange jumpsuit mode.
We are going.
I love it. I love it.
We want to be able to extend this technology out to be able to impact and hopefully capture some of these folks before they, get back on a wrong track or their disease or chronic condition.
So you're having some high-level interface with Department of Corrections and getting this down to the level. How about the military side? Obviously, Colorado Springs and El Paso County is a very big military town. And Evans Army Hospital, you got Fort Carson, the Air Force. What's happening now in terms of the military overlays or connection into this community network? I know about the Pikes Peak Military Care Network and what they're doing to kind of connect that model. How is that interfacing now with the civilian healthcare information exchange? Are there some interfaces and liaisons going on between the bodies?
Certainly. I think you could, if you wanted to draw a parallel community, it would probably be San Diego would be the closest. And one of the reasons is, so in our community, believe it or not, Medicaid as a payer for insurance, a payer, is about 30% of our population. Military is about 30%.
It's right up there.
So the two of those combined is, well
the
over
big 60.
Over 60%, and the other third, obviously, commercial paid or self-insured. So yes, and same thing in San Diego with all. And I want to bring that up because I was recently down there speaking with their HIE and looking at their progress with the DoD. To answer your question, one of the nice efficiencies on us connecting with Creo and moving forward in this partnership was simultaneously the DoD was doing the same thing. And so I worked very closely with Colonel Dominici, who is the military CIO out here. And so we actually, I don't know whether or not this has been completely test verified yet, but I think it has been.
We're not making any advanced press announcements.
Well, especially when we're talking about government people looking at this.
Disclaimer.
But so if you can imagine, then the ability. If I can give you an example. So one of our primary care providers provides what they call a pop-off contract. So when military docs are deployed, the civilian practice takes over for them and fills in for them. So you can imagine then the requirement or the need for those civilian docs to have access to that patient's military records and vice versa. When the military physician is back, they'd want to see that event. So sounds easy, not super easy, but it's very cool. So now actually a doc here on the civilian space can retrieve through the military system, through Creo, which is the engine for all this, and then receive that patient's information, make their treatment diagnosis, close their notes, the clinical file, which would be then viewable and retrievable back on the base.
Now, was this predominantly for active duty personnel, or would this also be for people who now have discharged out of the military? Because I had an interesting conversation with Tom Hardy, obviously the Fort Carson, the Army Hospital side, and he told me some stories about the VA has their medical record distribution is coming off of CD-ROM. And how did you guys get this CD-ROM integration back into the normal community health records for that? Now, what used to have been a military personnel is now transitioned to civilian life. Does that happen smoothly, or are you guys envisioning ways of making that transition more effective?
It's clumsy, like any new technologies are. Some are more advanced, like the example I just gave you is probably as good as it gets.
We ought to sign up for that one, right?
Exactly. But so I think retired military personnel can fall into several groups. Some of them not as well taken care of or with technology.
This is true.
Right. Many of them fall into a behavioral health category. Many of them may or may not be on Medicaid or Medicare. Many of them have VA benefits. So you can see the various different systems that are not the best connected. So our focus right now was to try and focus on one community that we could try and manage and control and do some analytics on how good our efforts are being are affecting people. And so we're looking really at military, active duty type crossovers and the Medicaid population for now. And we look at expanding that.
Well, you know what's interesting is that I've had an opportunity recently, within probably like the last 9 months, I've been meeting with Rocky Mountain Health and Human Services. They had a large $3 million remit from VA to help homeless veterans. And so we've kind of dived into the information management structures within the VA, within, I believe it's Pikes Peak United Way actually has a component in that as well. And so there's some challenges there in terms of getting this information through the pipeline for transitioning vets. So I would definitely like to see some more interfacing going on, not only between those bodies, but your organization as well as Carrillo. So that's one of the things that we've got a new healthcare IT and cybersecurity center of excellence that we're putting together. So we're looking at this fusion of healthcare IT requirements, what's going on the security side, but a lot of this really gets down to the base of the pyramid. How are we getting all this information connected up and bringing it up through this stack? Right. So a couple of other things I want to maybe do a little policy weeds, and then we'll kind of cover the stuff on workforce. I know, and we talked a little bit about this meaningful use requirements when the ACA first came out, and they put all these mandates in. I believe there was 3 phases that the technology organizations and the health organizations were going through. And there's been some talk that meaningful use has actually run out of meaningful use, and that there's obviously some new issues that are coming online, like continuity of care documents and care records and new things to get this down to the community level. These are some of the areas that you're focusing on and differentiating to follow that path of, meaningful use was great, but we got to really do the job locally now, so we're going to go in this other direction.
Certainly, and so I'll talk maybe more toward the continuity of care document side of things and outside of the EHR side of things. So the EHR part of it is associated with the financial reimbursement.
Pretty much nailed down where the money flows.
Exactly.
Right.
So the bigger picture, though, is that you could spend your time with. So when you talk about the hospital systems, the majority of them are on an Epic system or a Meditech,
right.
So very few vendors that manage that space.
Right.
But in our efforts, we're looking at, say, I said 30 providers we're going to be onboarding.
Right.
I would venture to say that at least 15 to 16, 17 of those are different EHR systems.
Really?
So the technology is very complex, as opposed to building bridges, so to speak, on that. The whole idea behind our project with Carrillo and our partnership is to build more around the continuity of care of document architecture. The way this document comes in from different places may look a little different, but the Carrillo engine and magic then takes different pieces, data elements that may be different. It kind of puts them in and looks at them, verifies, oh, that's what this is from this doctor, and that's what this is. And then rendering that back into a view where another provider can, they are all seeing the same thing. So that's really where we live in
where
our
you're
project
heading.
Right now.
Got it.
Right.
Do you see the impact of mobile devices really having some play on this from the usability, UI, UX standpoint for end users?
So, yeah, certainly.
Okay.
I mean, in defining the end users is important too, right? So there's obviously privacy issues that are going to abound in our
and security.
Yeah, and security issues. But from a care coordination standpoint, so being able to have the person coordinating care, providing care, immediate access to all the things we're talking about, which is clinical data from an HIE, maybe their own EHR data.
How about family member access?
Family member access as well. But for a provider to be able to have that, it's got to be mobile, tablet oriented, or it's just not practical.
In some of your trials, have you guys actually been able to do some tablet deployments and testing in that regard?
We have actually. A good segue for me to give you kind of a new success for us.
Perfect.
One of the areas when you're talking about SET clinics and some of the folks that don't have that, one of those folks in our community is the fire department, and our CARES group is a part of the fire department that actually responds to 911 calls. They do checks and house checks on people.
And actually, I've come in direct communications with the CARES group of CSFD because they obviously sit in the Rocky Mountain Health and Human Services Committee group.
Yep.
So we're learning more about their outreach in the community. So are they now using tablet solutions from you guys?
They are off of paper. And
Very
I actually
good.
went on a ride along with them Wednesday of this week and watched it in action. So they're able to actually develop care plans and care records in a digital form that are now we're in test phase of bringing that into our data warehouse. with the idea then eventually is to hopefully feed that information up to Creo for them.
Well, folks, this is actually new information for me, and I might actually drag Jim into one of these RMHS meetings in a couple of weeks and have him talk, because this is actually some of the topics we've talked about with CSFD and the CARES group as they're reached out to the veteran community. We have a huge, veteran homeless problem in this community. I think it ranges anywhere between 150 to 200 pretty much every night on the street. And with a military town like the size that we have, this should not be happening. So, and again, so this reach out group of doing these intakes absolutely has to get automated. And we were looking at evaluating some of their paper-based and spreadsheet-based, and it's absolutely archaic. And if you're telling me you've already got on a tablet mode and you're moving, this is going to be great news. So
it's easy to forget sometimes people whose names just on a piece of paper, but when it's in a digital form, there's an alert that goes to someone and reminds them.
And again, folks, this is not artificial enthusiasm. I've been meeting with these groups for a long time, and this is really great news. So I really want to see more of that actually go forward. So let's kind of dive into this, the workforce orientation. I'm going to ask you these standard questions. So in your position, in doing what you're doing at CHP and looking at, this from a technology standpoint, obviously you're going to have to put your HR hat on and look at the broad spectrum of needs in terms of healthcare professionals that you need to keep doing what you're doing. You need to reach down to the collegiate level and see what kind of pipeline is coming in from a workforce standpoint. So tell me what you believe the caliber of individuals you're going to be needing in the future. What areas of focus should they be working on that really starts to address some of these community needs, and kind of give us your perspective from an HR standpoint.
Sure. So let's talk more about social characteristics first.
Okay.
We have a very unique situation. I don't know how familiar you are with CHP, but it's founded by a board of directors. It's been here for over 25 years of the leading senior executives of the healthcare.
Yeah, it's a well-entrenched organization. You bet.
And so because of that collaboration, it affords certain advantages for us to be able to capture and partner with a lot of these providers. And the reason I tell you that it's a very collaborative and a very community-oriented environment. So somebody that is comfortable in that environment, dealing with everything from social services to the welfare of folks, to Medicaid, to hospitals, to the fire department, to foster children, to long-term care needs.
It's a big
at least understanding that part of the world exists, because many people that aren't in that environment don't get it.
That's right.
I think a second part of that then would be we have a big care coordination requirement, and that's one of our functions that we do, is trying to get out and find impactable scenarios, and be able to reach out to those people. So the technology, and I'm not just saying this because I work in technology field, it really is becoming more required in things that may have just been a social worker type skills. Now you need to also understand certain levels of technology.
So we're really talking about a hybrid social worker / IT specialist. I don't even know if there's curriculums that exist like that today.
Nowadays they're probably 9 years old and they know how to do all.
Note to UCCS. We'll be coming at you.
Keep the kids on their iPads.
That's right.
From a technology standpoint, it's very different. I'll give you an example of the types of things we would look at. I don't think you can hire the first one, which is we have a practice outreach transformation group. And so there's trust built with the providers, with them. So it makes it very easy for us to make changes with respect to connectivity to HIE, et cetera. But a good community type communicative style for that type of person. For a back end type person, of course, data analytics, population health analytics. But I would say one that people might not really think about, workflow is the biggest barrier, just getting in the doc's way, interfering with workflow. So for those kids that are looking for some things to look at, but BenitaSoft is something that we're looking at, workflow processing tools to really look at one event triggers 7 others, and so that person doesn't have to do it, and then connects back in. And this is something that we're working on to try and get technology out of the doctor's way.
Are you building this in, say, a SaaS cloud model? You want to be able to push this into...
We're in the lab right now. We're in the Petri dish of that.
So this would be a good time for some really good, say, high school and college-bound bit diddlers or technology guys that may be pushing some of the edge of the boundaries to start working in some of these areas.
It's very cutting edge.
Do you want to see more of the university structures locally, not only within El Paso County, but throughout Colorado, coming and talking to you more to learn more about these requirements? Has this happened enough for you?
It has happened. I think it will happen more as we build this out, this technology out with Carrillo and across the state. I will say UCCS has been a wonderful community partner of ours, and we've found many interns and folks during the summer to come work with us. So no, I think it's a very good effort here. I can't speak on a state level. I don't know, but it can't hurt.
Excellent. Well, listen, James, I really appreciate your time today, and we'll see you back in the panel. We'll dive into some other topics. That's our second interview, and appreciate you joining us for our next one. This is Mike Schmidt, Ensemble Ventures for the Workforce Enablement Seminar Series. Thank you.